Welcome everyone. This is session 3 of our RaCEEs course, and today we're going to talk about costs. And I'm going to co-run this session today with Luis. Luis ran the first session for us, and is going to run this session with me today as well. So what we're going to do today is talk about the costs of an economic evaluation. So we are right within the methodological aspects of an economic evaluation. In session 2, we talk about the key attributes. Today, we're going to talk about cost, and then in the next session with Misael, we're going to cover outcomes. And in terms of the sections of the commentary, which we're going to produce at the end of the course, the cost and the cost data are going to be part of the method section. So we are extracting, or you are extracting a lot of information from the paper in your own team. So after session 2, you worked on the key attributes of an economic evaluation. After today's session, you will be asked to extract data regarding cost, and then after session 4, you will be asked to extract data regarding outcomes. And then with this data, the team leads will try to write up all the information for the method section of the commentary. After the workshop, we will have a first draft of the commentary, and then in the weeks and the months after the workshop, we will prepare it. You will be able to review it as well, and then we will try to submit it to an academic journal. So that's our final output, to have a co-produced commentary ready to be submitted for publication. So what we're going to cover today. So the aim for today is to identify and describe the characteristics of the cost data used in economic evaluation. We are going to talk about total costs. And then Luis is going to talk about resource use and unit cost. And then we are going to cover a bit currency and price here as well. Now, this is a diagram which I think you saw in session 1, if I remember well, and it's the typical diagram which depicts an economic evaluation with two alternatives. Alternatives which could be two different treatments, drugs, or generically interventions. Here we got alternative A and alternative B, but of course we might have more than two alternatives in economic evaluations. Probably in some of the papers you are analyzing there be maybe 2 or 3 economic interventions that we need to consider. But just in a nutshell, each alternative is associated with some costs and consequences or outcomes. And today we're going to just focus on the cost side. So we start with introducing the concept of total costs. And total cost, as you might expect, is something that is going to be expressed in monetary units, and it represents the total amount of cost, basically, that is associated with a specific intervention, a specific alternative. And it is made out of 2 components. One is the resource use, and the other is unit cost. So when you will see your paper, you will be able, or you should be able to identify the 2 components related to total cost, resource use, and unit cost. If the authors did a good job in terms of reporting the 2 components, they should be clearly defined and reported in the article. In particular, resource use is something that we express in natural units, and I will give you some examples in a minute, while unit cost is something we express in monetary units. When we multiply resource use by unit cost, and we get total cost. I'll give you an example. So if you think about medication, there might be some treatment which require using medications in order to make sure that the patients are cured or have a good quality of life. The amount of medication will be your resource use. So it's the amount of that specific resources you are using. In the same way, you're going to the supermarket and you need to buy some ingredients to, I don't know, bake a cake, for example. you will need X amount of sugar, X amount of flour, and so on. That's your amount, and that is expressed in natural units. You might need 3 medications, for example, or 4 sessions with a therapist, or 1 consultation with your GP. Okay, so that's what we mean with the resource use. Now, to obtain total cost, we need to monetize this amount, and the way we do that is by considering, okay, what is the cost of 1 medication? What is the cost of 1 session of therapy with, for example, a physiotherapist? What is the cost of a 10-minute consultation with a GP? And that's your unit cost, okay? So that's going to be expressed in monetary units, and when you multiply the resource use with the unit cost, you obtain a total cost for a specific resource. So 3 medications, for example, and you know that 1 medication might cost 50p. Total cost of medication will be £1.50, for example. When you then add up all the different total costs for medications, surgery, equipment, staff time, and so on, you will obtain the total cost for a specific alternative or intervention. So it might sound quite simple on paper, at least, and it's not actually that difficult to calculate total cost. It's not something we are going to ask you to do, but when you will see total cost being reported in an academic paper, they usually describe it in this way, where the authors will have collected some resource use information, they will have to obtain some unit cost information, and then just do this multiplication to obtain total cost. I'm going to give you now some example of type of costs which researchers or health economists consider when they run an economic evaluations. I already talked about some examples before, but I'm going to give you even more examples in these slides. So there are different families or groups of costs that researchers consider when they run an economic evaluation. Here we have some example regarding direct medical costs. Direct medical costs are strictly linked to the provision of healthcare. And here you can find a list of things which are very much linked to the provision of healthcare services, for example, generic care, medication, consultation, treatments, and so on. We also have another group of costs which are direct non-medical costs. These are broadly linked to the provision of healthcare. And again, you can find some examples here regarding travel, accommodation, food, or modification. So these are not really strictly linked to the provision of healthcare, but they are linked somehow to receiving some healthcare services. For example, patient travel, accommodation if the families need to stay in a nearby hotel, for example, food which might be provided by the hospital, for example, or modifications when the patient goes back home, they might need to do some modification, for example, to some part of their houses, like shower or the stairs, for example. So these are all direct non-medical costs. And if we go a bit more widely, we can consider also some indirect costs, which are things that might be, or costs that might be incurred by the patients, for example, lost income. So if patients have to take some time off work, they might lose some salary. The same for their families and their caregivers. Again, if they have to take some time off work to provide care for the patients. At the same time, lost work days will have an impact on, for example, the companies where the patients work, and that means that the company might have to replace a person temporarily or even permanently sometimes. So there might be some productivity losses as well, which are important to consider. Why am I telling you all this? Because you will remember in session 2, we talked about perspective and economic evaluation. And the more you broaden your perspective, the more you will try to capture things like, for example, direct non-medical cost or even indirect cost, if that is possible. Of course, you probably see already that some of these costs might be tricky to capture. For example, lost work days for patients, productivity losses. It's not always straightforward to capture these costs. What I can tell you is that as a minimum in the UK, at least, any economic evaluation should try to capture the costs within the health or the social care system. So direct medical cost or direct non-medical cost. Anything that goes above and beyond that is of course a bonus. So if you will see economic evaluation which have an healthcare system perspective and also a patient perspective, or even a societal perspective. So where they're trying to capture spillover effects over other sectors of an economy. Okay. And I think you got some examples in some of the papers the teams are analyzing that there are possibly some societal perspective being embraced in these papers. But as a minimum, at least in the UK, economic relations should look at costs from the healthcare or the social care system perspective. Any questions so far? Okay, I think I will hand over to Luis now. Yeah.
Sorry, I think I was muted. For some reason, my Zoom is playing tricks right now. Why did it do this? Well, doesn't matter. So can you see it?
I think it's loading. Let me see. Yeah, now we can see it. Yeah.
So okay. So Valerio was just explaining you about how you compute total costs. So it's very simple. You need the resource use. So let's say the number of doctors, the number of nurses, the number of medicines, etc. And then eventually you try to find their costs and you just multiply. So that is the summary, right? So so now let's talk a little bit more specifically about resource use. So the resource use, again, Valerio already explained you, is precisely the resource, the use of healthcare. So the resource that you use in healthcare, so it can be the healthcare time, so the physicians, nurses, etc.'s time, the facilities, the consumables, you have here especially the medicines, etc. So just do the following. Think of a surgery. So let's say a knee surgery, and try to think of everything that would be needed for that knee surgery. So think about the staff that would be needed, the facilities, all the consumables, etc. So we will come back to this at the end of the slide for you to share what you could think about. But everything that you can think about that would be needed for that intervention, for that surgery, should be counted as resource use. That later you will try to find, let's say, the costs, and then multiplying both, giving you the total cost. Now, Valerio was talking to you about the perspectives, and there are several perspectives. You can have the patient perspective, the payer, if the payer is not, let's say, the NHS, you can have the healthcare perspective, so let's say the NHS perspective, or you can have the society perspective. And this may seem, I don't know, confusing at first, but it's very easy and intuitive. The only kind of the only thing that you need to think about is for whom are you doing the economic evaluation, and you just need to put yourself in their shoes, and try to understand what they need to pay, what type of resources are they going to pay for. So let's, for instance, consider the patient. If you consider the patient perspective and imagine that you are outside of the NHS in a country where you need to pay out of pocket for the healthcare that you receive. So you go to a doctor, let's say to a GP, you are probably going to cost the money that you spent on the consultation and, for instance, travel time, right? So it's literally that. Put yourself in the shoes of the person or the company or the entity paying for the healthcare. So if you are in the payer, for example, let's say here it's a little bit weird because Usually the payer is the healthcare system, so the NHS. But let's say, for instance, in the US, where the market is a lot based on insurers, what would you count, let's say, in this knee surgery for the insurer? So it would basically be the price, right, of the knee surgery, which would be impacted by, of course, the staff time, facilities, consumables, etc. But now, what would be the difference then if you consider the healthcare service? So, for instance, the NHS. Well, sometimes it's probably going to be very similar, but in the NHS, for instance, you would care about the costs exactly of those resources. Let's say you cost everything around the NHS that is going to produce a knee surgery, for example. While for the payer, for the insurer, the price may be different. So the hospital may cost them a little bit more than what it costs to the hospital. So for the payer, you count the price. For the hospital, for instance, you count the cost. And then you have society, as Valerio explained, as in which you tend to account for the indirect costs. So you tend to account for instance, informal caregivers, you tend to account for losses of productivity. So let's say that an intervention is going to save time in terms of informal caregiving. You could go and try to understand how much informal caregiving was saved because of the intervention and try to compute the amount in terms of financial resources that would be correspondent to. You could try to find the losses in productivity, etc. So the society perspective is a perspective where you care about everyone in the society. So you will count absolutely any costs that you can that are indirectly or directly related to the intervention. Now, in terms of resource use, what you will see is that you commonly record items such as GP or specialist visits, hospital admissions, hospital bed days, medication administered, and so on and so forth. Now, before we go to our example and try to see how much you would need for an intervention, I have here just a note basically for when you are doing your when you are looking at your paper, at your homework, etc., and when we are trying to write the commentary, which is that the resource use collected in clinical trials may be of limited value for economic evaluations because of the inclusion of protocol-related elements. So in here, I have the examples of study visits or care in specialist centers, which may not be representative of routine care. But let's just translate this. What I want to mean is that when you look at your paper for your commentary, try to understand whether the intervention that they are describing in the paper can just be like plug and play when it goes to the National Health Service, let's say. This is something that we are going to always in our RaCEEs, in our commentaries try to do, is to understand how generalizable it is. If it is just, okay, put it there and in the health system and it's done, or if there were special conditions during the clinical control trials that made it feasible there, but that will not be available once you try to generalize it to the current care. So that said, let's then go to the example of the knee surgery. So we have only two people today, right? So Taylor and Matt. So please, if you care to participate, just don't worry, just very briefly, what can you think about, like, if you have to go for a knee surgery, what, hopefully not, what would they need to have in the hospital in order to be able to perform the knee surgery?
I mean, there's like the actual surgeons and doctors themselves, so the staff time.
Mm-hmm.
I suppose like the room that's being used, and all the costs that are associated with that.
Mm-hmm.
And then any sort of medication that's needed as well. It's like consumables.
Yeah, I think in short it would be that, right? So doctors, nurses. I think what is the name of the person who gives the anesthesia? So
Anesthesiologist.
Sorry?
An anesthesiologist.
Yes,
The anesthetic.
precisely. Mm-hmm. So the facilities, yeah, I would assume at least a surgery room, I would guess. Something else?
Hospital days afterwards if they need to recover.
Yeah, so I would assume so. Also, I would assume, like Valerio was talking about the indirect costs, like meals. I would assume meals at the hospital if they need to stay there, and of course they need to be fed. Yeah, so consumables. So you already told the anesthesia or any other painkillers or whatever they need to give the patient after the surgery. Anything else?
The indirect costs to the patient, how much time they're going to take off work, how much wages they're going to miss and stuff like that.
Okay, but that would depend on when would you count those?
Sorry, if it's for society.
Exactly, exactly. So yes, so definitely, then you would probably try to understand productivity, the days of work that they are losing or gaining, because sometimes it's just an intervention which marginally makes you recuperate a little bit faster, and because of that, you probably lose a little bit less in terms of productivity. So. Yeah, so I would assume that would be it, right? Now we could count even if we want like electricity or water or whatever. So everything else that needs to be there for an hospital to work, but that would be the case. Now, also in both the society and healthcare perspective, probably this is a little bit trickier. But in an intervention, you could also count in the part of the costs that well, you could also count, for instance, averted situation. So let's say that the intervention is going to be good enough so that it avoids further rehospitalizations or stuff like that. That would also be able to be counted as costs saved. So that's the type of things that you are going to find in a paper. But yes, I think that would be more or less it. So I'm probably going to get it to Valerio.
Thank you, Luis. So this is a quick slide just to kind of covering the way we can collect resource use in economic evaluations. I'm going to give you some examples here, given our experience of running economic evaluation and trying to capture resource use data from studies. For example, you might know about case report forms or CRFs, which are typically collected by site personnel, so research staff employed in a specific site like hospital or clinics. And they will be tasked to collect specific resource use information regarding the patient, for example, how many medications they had, how many consultations they had with whom, and so on. This type of information can also be collected through patient questionnaires, where we actually asking directly the patients what kind of resource use they consumed within a specific time period. Or we could ask them to collect some diaries, so they keep a log of any type of contact they had with the health or social care service within a specific period. All these methods could be validated or complemented by using, for example, electronic health records. So the information that we get from the patient regarding their resource use could be validated, double-checked by using, for example, electronic health records in order to make sure that the actual information is correct or accurate. The same can be done with other examples from the literature. So there might be longitudinal studies or core studies, for example, which follow people with a certain condition for years, and they might have an understanding of how many consultation, medications, for example, people with diabetes or stroke will have in 5 years, 10 years, and so on. So there will be an expectation of the number and type of a resource use that these people will have. The same with the data set reporting this type of data, or even public sources like guidelines. Okay, so when we have, for example, nice guidelines regarding the treatment of specific condition, if people go through a specific complication, the guidelines will tell you to, okay, this person will need to have, I don't know, oxygen medication for X number of days, things like that. So there is an expectation regarding the resource use that patients are expected again to consume as a result of having a condition or a specific complication. All I want to say now is regarding the pros and cons of using these methods. For example, we tend to use quite a lot patient questionnaires in our studies because we are able to interview the patient directly and ask them about how many resources they use, for example, in the last 4 weeks, 3 months, whatever that is. But there's always some trade-off here because, of course, you want people to recall what they used. And if you ask people with, for example, stroke or cancer to recall what they used in the last 3-6 months, there might be some difficulties for them in trying to remembering everything they use in that time period. So there is a trade-off in that sense because at the same time, if you trying to administer a questionnaire every 4 weeks, that will constitute a burden for some people, okay? Especially people with cognitive problems. So we need to consider as a health economist sometimes this trade-off between frequency, recall, burden, and it's not always easy to be able to capture everything in an accurate way. Within your paper, later on after today's session, you will be asked to extract some information about the sources of resource use data. And again, these are some examples, and there are probably other examples, but I would say these are the most common examples of sources of resource use data. So the authors might say we use patient questionnaires, we use CRFs, we use electronic health records, and so on. And if you are not able to identify, maybe they didn't do a good job in terms of reporting that, and we could explain that and criticize that in the commentary. Any questions? Okay, over to you, Luis.
Okay. So we talked about the resource use, so the units, so the number of the time of physicians, nurses, etc., the number of drugs that you need to administer, the number of rooms and other facilities that you need, but then you need to give them a cost, right? And how do you do that? And you will see that usually we use what we call the unit costs, which is the total expenditure incurred by a company. And here we have a company because it can actually be, for instance, a private company. Here we are talking about healthcare, and it's usually, for instance, in the UK, it's going to be mostly the NHS. But this is an economic term, so it could be applied to basically any country, any company producing any type of product. But well, the unit cost is the total expenditure incurred by a company to produce, store, and sell 1 unit of a particular good or service. So 1 unit of a particular good or service, let's say in the healthcare scenario, if we are talking about, for instance, an admission to the hospital, it would be that admission. A GP consultation, it would be that GP consultation. And sometimes you will see that the cost can be very directly inferred. Sometimes it will not. So let's go back to the example of the knee surgery. So for instance, we said that we would have to account for the staff time. So how would you cost staff time? In fact, that one is probably not that difficult. What you need to do is to understand how much they are paid, right? And you probably have that they are paid a certain amount per month. You can do it per hours because you know how much hours they work. In fact, there is probably a salary per hour already. So you can see that a physician, a nurse, etc., they are paid a certain amount per hour. Then as you told, you need to understand what is the number of hours that a knee surgery takes to do. So of course, knee surgeries, different ones. If you do several knee surgeries, they are not going to have exactly the same time, but you can compute the average. So you can say that, let's say that knee surgery has an average time of 2 hours. So you can literally go there and compute how much does it cost in terms of salary to have a doctor for 2 hours, a nurse for 2 hours, etc. Then you can probably compute the average amount of medicines that are used. So those ones would be more or less easy to do. Then you can probably, so you need probably to cost the facilities. How do you cost the facilities? So it can be the rent. Imagine that the hospital needs to pay a rent to have that space, that building, etc. Even if not, this is the question. Let's say that let's say that the hospital owns the physical space. Should you still count the value of the facilities anyway, the value of the building in any way? So this is a question. What do you think, Taylor and Matt?
Sorry, I lost connection and I didn't hear the question.
So let's say that it's the NHS and the NHS owns the physical place, owns the building, owns everything. Should you still cost anything about the building? Since you don't pay rent, should you still cost it?
It still costs in upkeep in the building. They still got to pay outgoing. There's still outgoing somewhere in the NHS to look after the building. I forgot what people called who would look after the building, but
No, but this is a tricky question because even if, let's say, you have the building, you still need to cost it. You need to cost the opportunity cost, which is whenever you decide to use that building to provide care to people, you are not using that building to do something else. So, and what is that something else? So let's say that instead of providing care to people, being there to provide healthcare, you could rent the building to a company, let's say, and receive rent. So you still have to cost the opportunity cost for not doing something else with the building. Okay. So yeah, if you are paying rent, you count the rent. If you own the place, you still have to count the opportunity cost. Most of the times it's probably rent anyway. You count the rent that you relinquish by using the building for that purpose. So other costs that you may need to compute, so let's say the electricity, water, etc. So it may be slightly complicated because you probably need to compute everything that the hospital uses, and then you probably have to try to understand what bit of the electricity bill needs to go to knee surgeries and to that one specifically that lasts 2 hours. But well, there are methods to try to do some things like that, and then imagine that you adopt a societal perspective, as you were assuming in the knee surgery question. So how to compute the unit costs of informal caregivers, for example. So again, a question for you too. What would you do? And let me tell you that the answer, whenever it is not directly, so you already have it in the bullet point, the answer is usually the opportunity cost. So what is the opportunity cost of informal caregivers? And that is probably going to be their costing. Or to the system, the opportunity cost to the system, instead of having informal caregivers, if they had to have other people taking care of the person. So okay, if I'm spending 2 hours taking care of a family member, I'm not spending those 2 hours doing something else, and that needs to have a cost. Okay, so it can be, for instance, salary. You can try to compute what would be the average salary of a caregiver, and you just say that if the person is they are spending those 2 hours providing care instead of working. So that can be the opportunity cost. So you can compute the salary, which can be minimal wage, it can be average wage. Then you try to understand what are the type of person providing care and try to understand what would their salary be if instead of providing care they were working. Now you can also assume that if you didn't have an informal caregiver providing care, you would have a formal one. So you can compute what would be the cost of a formal caregiver. So let's say if every day, again, 2 hours every day of informal caregiving, what would be the cost of 2 hours every day of formal caregiving, for example. So you use this opportunity cost as a way to infer these indirect costs that you just don't have a direct number for, okay? So any question about this?
Where do you get an average wage from? Like,
where do you get it? I told you that, but that is a potential assumption. But you probably, let's say it is in the UK, and you assume that the opportunity cost of the informal caregiver is the average wage. You just go, well, you mean specifically. Good question. So I would say the Office of National Statistics. Would I be right, Valerie? Sorry, because it's UK. But I think so. I think you can get average wage there.
Or you can ask actually the informal caregiver to give you an estimate of their
Or
salary.
that, yes.
Yeah.
Yeah, but if you are making assumptions and you are just using, let's say, the minimum wage, so or you are using the average wage, I would assume that you can find it in sites like the Office of National Statistics, right?
I think so. Yeah, I think so.
So, okay, any other question? So, okay, so here I'm just going to show you some sources of data. So you have, for instance, the NHS reference costs. You have the link in the slides, so the slides will be shared. And if you click it and if you search for it, you will see that it has a lot of costs related to the NHS. So, for instance, you will be able to find emergency care costs, critical care. You are going to find costs related to diagnosis. So feel free to go there and explore. You are going to find a lot of unit costs. Now, just one thing that I'm not sure if I said, which was we were saying knee surgery, and we saw that it can have all those costs. So the unit cost is putting all those costs together. So of course, in some way, it is already going to be slightly aggregated. Most of the times, you are going to find the unit cost for any surgery already, and you can already apply that to the study, to the economic evaluation. Now, other source of unit costs can be the unit costs of health and social care. So here, of course, for social care, and I'll show you the examples of this one in a while, because not so long ago I had to literally come here and find some unit costs that I was interested in. So I'm going to show you what I did. Then you have here the British National Formulary, which is mostly for drugs. Again, you have the link, so feel free to use the link and go and explore a little bit by yourselves. So now just an example of precisely the one I told you, the unit costs of health and social care. So this is something that I actually did, and here you can precisely see what I told you. So you have the cost and unit estimation in the first column, and then you have the specific value in the second column, and then in the third column you have the notes explaining what it is. So you can see that we can start, for instance, here with a salary, and you have the salary of a social worker, which is in the second column. So you can have here the 37 and 600,000 pounds. Then other costs. So you have salary on costs, which are basically, if you go to the notes, you can see that it is basically the national insurance contribution. So you have the salary and you have the social security contribution. Now, other things that you may need to pay for a social worker. So initial qualifications. This is going to be dependent, so you can again read the notes, but it is basically training that may be needed for that person to be qualified to be a social worker. Then ongoing training, in this case you have no values, but that could be other sort of training that you need to keep doing in order to have your social worker prepared. Then you have the overheads. In the overheads, you have, for instance, the direct overheads, which include costs to provider administration and management, as well as office training and utilities such as water, gas, and electricity. Then you have indirect overheads, which are management and support services such as finance and human resources. Then you have capital overheads, which are related with the building and requirements for local authority office and shared facilities for waiting interviews and clerical support. Then you may have travel, if that is the case. In this case, there is nothing, no information available, but it could be another item. Sorry, yes, and that's it. So if you sum everything, if you sum all the items that you have in here, you have the total costs of a social care worker. Then there are several ways where you can show the cost. You can show it by day, you can show it by hour, or you can show it by week. I would say that commonly you see it by hour, but still you have here the working time. So you have the working time by days per year, by hours per year, and by weeks per year, depending on what you want. If you want it by day, you divide the total cost by the number of days. If you want it by hour, you divide it by the number of hours. If you want it by weeks, you divide the total cost by the number of weeks. In this case, you are going to see here down below that it is shown per hour. So it's basically dividing the total costs by the working hours per year. And you will see that the cost of a social worker per hour with qualifications is £53 for this. So what is the year? 2022 and 2023. And without qualifications, it is 44. I assume that, it's about these initial qualifications. Now, it's also important to tell which date it is, because there's a thing called inflation. So money today is not worth the same as money tomorrow. Money today is worth more. And then there is inflation. So the values of 2022, 2023, if they need to be applied today, they are probably a little bit higher because of inflation. Now, any question so far? If not, I'm just going to show you how usually you can find the information about costs in the paper. So this is the first RaCEEs paper that we did. And you can see here on the left in this Raj et al., which is ours, you can see our summary of the costs. And in fact, it is very small. Because we need to be very objective in these commentaries. They are usually small. But while this is very small, it is not as small when you go to the actual paper. So in the actual paper, we went to the cost section, and there was, even within the cost section, different subsections, let's say. And you can see, for instance, that in this first paragraph, we have the costs of the intervention, the practical stuff of the intervention in itself. So this is a paper about this LCIG treatment for Parkinson's disease. And this LCIG treatment is basically you need to do a certain type of surgery to insert a cassette. I think it's in the intestine, something like that. And then the cassette, if I understand it correctly, is going to kind of give the medicine. So I'm not finding the right word, but it's basically the patient takes the medicine through that cassette. So this first paragraph is talking about the costs related to that. Then the second paragraph is mainly talking about the costs of other material needed in order to do the intervention. Then if you go to these other subsection costs associated with the health states, this is something different, which is Parkinson disease, depending on the state where the patient is going to cost differently. So being very simple, if the patient is in a more severe state, the patient will cost more. If the patient is in a less severe state, the patient will cost less. And if the intervention makes the probability of the patient being in a more severe state lower, then the intervention is going to save in terms of costs. So this part is precisely saying that the costs of each state. And then finally, this last part here below is talking about the costs of the staff, explaining that most of the costs of these states are going to be related with staff. So here is just an example how in that paper, in this paper by Chowdhury et al., how they show the costs. So I went to check the table. So we have it here, and you can see how it looks like. So for instance, the medication of this LCIG, you have the resource use. So 1 LCIG cassette daily. So the resource use, and you have the cost here. So the cassette, 77 pounds, so equivalent to, so because this is per day, equivalent to 30,000, well, almost 31,000 pounds annually. Okay. Then you have the standard of care. Because the standard of care, we are comparing to the standard of care, there's nothing here to be said. But then other medications, so you have here the concomitant oral medications included in these COMT inhibitors, and you have again their costs, which are these 319 annually. So in this case, for standard of care, you have the oral medication that are given, and again, also the costs of this medication. And then I could go through it and show you everything, but it's always the same. So you have the resource use. So for instance, here LCIG startup, you have the tube of insertion, the different tubes of insertion, the monitoring, etc. So you can go through it and check it. You have all the resource uses, and then you have the costs. And if the standard of care, if you have to count anything for the standard of care in that item as well, you have it counted as resource use and then the respective costs. So here is just the end of the table. So with the adverse events, that you can see again the same, the resource use and the costs. And so that's it. Feel free to check it. Feel free to check the paper. If you have any questions, I'll be glad to answer. If not, I'll give it to Valerio. So any questions? So, okay, Valerio.
Oh, thank you, Luis. This is just a quick slide. I'm going to cover currency and price area. Sometimes you will see economic evaluations set in different countries, UK, Europe, US. And of course, when you collect resource use and cost in different countries, you have to think about how to report these costs. And you can't, of course, use individual country currencies. You have to make a decision around a common currency you're going to use to report all these different costs. So common currency is something that people will have to consider, especially in international studies. At the same time, there has to be a common price here when costs relate to different years. Like Luis is giving you a very good example how to find the information about the cost for a social worker in 2023. Now, there might be other costs which have been accrued, for example, in 2024. Okay, there might be some consultation with the GP which occurred in 2024. So the related cost was, of course, reported with 2024 prices. So at the end of the day, all these different costs accrued in different years will have to be converted onto a common price years. And that's something that, again, the authors will have to decide on and report explicitly in the paper. You can find an example here. Just a generic examples where all the costs were converted in US dollars and the price year was 2020, for example. And if you are interested more in understanding how conversions work, there is a link here to a cost converter, which allow you to convert costs from different countries to different price years and so on. Thank you, Luis. So, this is your homework for next time. We are going to have a table. So similar to session 2, you'll be dealing with a big table where you're going to try to extract some information regarding cost data. You will find this table on Teams session 3 folder. And then if you click on that folder, you will see a document with your name, a Word document with your name. You can open that document and you will see this table with the first 2 columns, which give you information about the type of cost data you need to concentrate on, for example, resource use data, and then you got a question, for example, which type of health or social care resources did the authors collect data on, and you got some information, tips as well about where to find this information. Typically, all the cost data should be in the method section of the paper. Sometimes it might be easier, quicker just to check the result tables as well of the paper. And what we're going to ask you to do is just extract this information and copy and paste it in. Just simple as copy and paste. You don't need to paraphrase things. You can just try to copy and paste information into the 3rd column here. So you'll have to do this for resource use data, for the sources of your resource use data. So again, the authors might say, we collect a resource use through patient questionnaire, through CRFs, okay? And this is your resource, the source of your resource use data. Sources of unit cost, as Luis was explaining before, could be public available sources like NHS reference cost, unit cost from publicly available databases, and so on. And again, if you got some information regarding currency price here, that's something you can extract and paste in this document. And that's it for today's session. So we'll see you in 2 weeks' time, on Monday the 30th, for the session on outcomes. I mean, Luis and I are happy to stay maybe for another 2-3 minutes if you got any outstanding questions. But we would like to thank you for attending today, and we will see you next time. Thank you very much.